If placenta is not delivered within the 30 minutes after the delivery of the newborns, and the woman is not bleeding and there is no signs of circulatory compromise, ensure that the bladder is empty and repeat 10 units of oxytocin and continue controlled contraction. Remember to never administer oxytocin via IV push. Do not repeat misoprostol for manual removal of the placenta. To help to deliver the placenta, encourage the woman to bear down, squat or breastfeed. Manual removal of placenta with no delay. If placenta or placental tissue fails to deliver within 1 hour and there is no bleeding of the woman is bleeding heavily or there is a signs of circulatory compromise, a woman can lose a life-threatening amount of blood in a very short time in cases of retained placental tissues. If bleeding heavily, first call for help. Then stop the bleeding by applying aortic compression and start resuscitation of the mother. Inform the woman and her companion about the procedure. Resuscitation. The woman must lie down flat with the head low and legs up to be sure the blood gets to her brain. Establish 2 large bore IV lines, 16 on each side and 18 size. Check the woman's breathing, blood pressure and a pulse. Administer 1 to 2 liters of normal saline or a ringer lactate, 1 bag at a time. You apply pressure to make the fluid go in the fast as possible. A general rule is that the blood volume, if lost, must be replaced by 3 times the volume in crystalloids. If blood transfusion is available at your facility, you take blood for blood type and the cross match. Drugs before removal. In order to bring a pain relief and relaxation prior to manual removal of placenta, you can give the woman morphine and a diazepam intramuscularly or intravenously. See drug list for details. In case of excessive bleeding, apply aortic compression while administering the pain reliever. Administer a single dose of broad spectrum antibiotics. Ideally, administer immediately prior to performing the manual removal of placenta. Either 2 grams of ampicillin intravenously or 1 gram of cephalosporin intravenously. However, do not delay placenta removal effectively hemorrhaging. Gloves. Put on the elbow long sterile gloves if available. Otherwise, use the normal sterile gloves. Even though sterile gloves can be used if bleeding is life-threatening. Remove the placenta. Insert a hand into the vagina and follow the cord into the uterus. Place the other hand on the top of the fundus to support the uterus. Keep the fingers tightly together and remove the hand slowly from side to side until the edge of the placenta is located. Use the edge of the hand to gently separate the placenta from the uterine wall. The uterine wall is very fragile, so be careful not to apply unnecessary force. Proceed slowly all around the placental bud until the placenta is detached from the uterine wall. Hold the placenta and slowly withdraw the hand while the other hand provides the counter pressure in the other direction. Palpate the uterine cavity and to ensure that the placental tissues has been removed. Drugs after removal. Administer an oxytocin drip. 20 units of oxytocin, 1 liter of normal saline or a ringer lactate. Infuse the oxytocin drip at a rate of 60 drops per minute. If intravenous oxytocin is unavailable, or if the bleeding does not respond to oxytocin, then administer ergometrin 0.2 mg intravenously slowly. If the woman has a no hypertension, then misoprostol 800 micrograms sublingually or rectally given. Tranexamic acid 1 gram in 10 milliliter of diluent per over 10 minutes IV should be given. Tranexamic acid has been proven to save the lives. See drug list for the further information on indication, dosage and frequency. Monitoring. Provide the continuous uterine massage to stimulate the uterus to contract and proceed to perform the manual compression if needed. Monitor the bleeding, pulse, blood pressure and respiration. Ensure the uterine wall is well contracted and every 15 minutes for the 2 hours and then every 30 minutes for the next 4 hours. Make sure to measure the woman's hemoglobin on the following day and recommend the iron supplement 120 mg 2 times per day for the 3 months. Manual removal of the placenta can prevent or stop the postpartum hemorrhage. Remember, in an actively hemorrhagic woman, never refer without having tried to remove the placenta or fragment of the placenta, and never refer her without being accompanied by a skilled birth attendant. See practical procedure. Continue to provide the resuscitation and aortic compression. During transfer, consider applying a uterine balloon tamponade prior to referral if bleeding continues. Thank you.